And now we're going to move on to our next panel. And for that panel, we're going to have look at the core foundations of serosurveillance. Our moderator is Dr. Prativa Baral, and Prativa is an infectious diseases epidemiologist, a newly minted PhD from what school is it? Johns Hopkins. I don't know where that is, but Johns Hopkins. So we're delighted to have Prativa here with us, and she is now a faculty associate and has worked with all sorts of groups, including the Bill and Melinda Gates Foundation, and she's our lead technical consultant in pandemic preparedness, also working for the World Bank as well. So Prativa, thank you, and we'll move to this next panel.
Thank you, Tim. Thank you all for being here and for braving the cold, and thank you for those of you who are able to join virtually. I am delighted to introduce two individuals who spearheaded and organized the Serosurveillance Summit at Hopkins last year, perhaps biased because they are from my alma mater. So I would like to present Dr. William Moss. He's a professor in the Department of Epidemiology at the International Health Department and Molecular Microbiology and Immunology at the Johns Hopkins Bloomberg School of Public Health. He is also the executive director of the International Vaccine Access Center, IVAC, and a deputy director at the Johns Hopkins Malaria Research Institute. He is a pediatrician with subspecialty training in infectious diseases and has worked in Ethiopia, Kenya, South Africa, Zambia, Zimbabwe, and India, among other countries. Dr. Moss is a principal investigator on the Strengthening Immunization Systems Through Serosurveillance project, investigating serological surveillance in Zambia and India to inform immunization programs. We're also delighted to welcome Dr. Andrea Carcelin. She is an assistant scientist at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health and within the International Vaccine Access Center. Her work focuses on supporting immunization programs to reach vulnerable populations through innovative surveillance of vaccine-preventable diseases and mixed methods research on improving vaccine uptake. She focuses on countries in Latin America and Africa, and her current projects include the strengthening immunization systems through serosurveillance in Zambia and leveraging the countrywide mortality surveillance for action for multi-pathogen serological surveillance in Mozambique. And so with that, we are really looking forward to learning from the lessons from the Serosurveillance Summit that was held last year and seeing if we can align our efforts. Dr. Moss, Dr. Carcelin, over to you.
Good morning, and thank you, Prativa and Tim. We thank the organizers for inviting us to this really important conference. I'm sure we're going to learn a lot from it. My colleague, Andrea Carcelin, and I were asked, as Prativa said, to talk a little bit about the core foundations of serosurveillance and really to highlight some of the outcomes of the Serosurveillance Summit that was held last March, when apparently there was a conference in Vancouver as well. Thanks, Tim. And so we're delighted to be here. I will mention it is Valentine's Day in the United States, and so this trip comes with a little bit of a cost, but I will have to buy some things and bring them back, I think. And to advance. Is there a clicker?
Yeah, that's the one.
Is this it?
Yes.
And I click. Okay, just press that. Okay, yeah. Thank you. Sorry about that. Okay. So just a couple words about kind of the perspective that Andrea and I are going to bring. First, we work largely in low and middle income countries. As Prativa said, our serosurveillance work or serological work has been in Zambia, India, and in Mozambique. And so it's quite a different perspective than, say, for example, the HEMANet, and we're really interested to learn, and I think there are cross-learnings across those settings. And our work, particularly in Zambia and India, has been largely focused on measles and rubella, and with that broader view of vaccine-preventable diseases, which raises kind of different issues, and Tim alluded somewhat to this, but I'll talk a little bit about this. So for example, the question of representativeness of residual specimens is different in a low-income country, particularly when you're thinking about vaccine-preventable diseases, because the children, for example, presenting for healthcare may be different than the children who are actually getting vaccinated. And the bias could go both, I think, in either direction. So there are issues there. I'm going to give kind of a brief overview, focusing on what I kind of see of two of the core foundations of serosurveillance. One, its feasibility, how easy it is to do, and its utility. And these are going to be themes that I'm sure are going to come up over and over again throughout this conference. And then I'll hand it over to Andrea, who's really going to take you through the outcomes of the Serosurveillance Summit. So this is kind of our schematic of different survey designs that can be used. And there are these trade-offs, and they kind of fall along the spectrum where kind of on the far right, standalone community-based surveys, we know these are very expensive, resource-intensive, but you have much more control over the study design, the study population, the information that's collected. And then at the far left, leveraging existing biorepositories or different types of residual specimens, whether I'll mention fever rash surveillance in Zambia and healthcare facilities, where you have obviously less control, less of the metadata that Tim alluded to, and there are trade-offs here. And I think the way we envision is very analogous to the way kind of Tim presented it. A serosurveillance system can be a combination of these data sources. It doesn't have to be just one. And so I think some of the work going forward is how you kind of bring together these different specimen sources and really leverage and triangulate the data across them. So, this just kind of picking up on this. And I will say in some circles that we are in, there is some skepticism around residual specimens. I'm sure you face some of that too. And again, the real questions of representativeness. And so, in our work, we have, and I'll show this on the next slide just very briefly, we've leveraged existing biorepositories, for example, or nested serosurveys within other types of surveys that aren't specifically designed to be serosurveys, but, you can take advantage of some of these opportunities. And then using residual specimens that many of you are quite familiar with. And as I said, a serosurveillance system can really be a combination of these different data sources. And so this is a project that has been funded for about 8 years now by the Bill and Melinda Gates Foundation called Strengthening Immunization Systems Through Serosurveillance. And the motivation behind this at the Gates Foundation a while back was that a lot of surveys were being done for vaccine-preventable diseases, particularly out of academic institutions, but they weren't really being kind of put to use by programs in low and middle-income countries. And so we were asked to select a country in the Africa region and the Southeast Asia region. It ended up being Zambia and in India, and to really try to show both really the feasibility and utility of guiding of serology and serological systems. And so in Zambia, we conducted a number of different types of serosurveys, and I'm not going to go through, I won't go through all the details here, but just to give you kind of a flavor, on the far left, we nested a serosurvey within what's called a post-coverage evaluation survey. So after a country like Zambia does a mass measles and rubella vaccination campaign, they do a coverage survey, a post-campaign coverage evaluation survey. And so, but they usually don't collect blood specimens for that. So we nested a serosurvey within that type of survey. We took advantage of a large biorepository. So countries like Zambia do periodic nationally representative HIV incidence and prevalence surveys. They had a biorepository of over 30,000 specimens. And so we got access to those specimens and tested about 10,000 of those specimens for measles and rubella serology, which gave us a very nice nationally representative picture of measles and rubella seroprevalence across the country, and I'll show you a result of that. We nested a measles serosurvey within a mass vaccination campaign called an SIA, or supplementary immunization activity. So as children were coming to be vaccinated in a mass vaccination campaign, we collected a blood sample, not traditionally done, and measured measles seroprevalence there. Now, obviously, that's not a completely representative sample, because those are children who are coming for vaccination, but it gives us a sense of what proportion of children being vaccinated in a campaign are actually measles seronegative, kind of what is the efficiency of this campaign. I'll talk a little bit more about this, but fever rash specimens are collected as part of a standard surveillance systems in countries like Zambia as part of their measles and rubella surveillance system. Those are tested for IgM antibodies to measles and rubella, but we tested them for IgG antibodies. We did concurrent collection of community-based cluster sampling design, two-stage cluster sampling was designed in a community, and concurrently collected residual specimens from the laboratories in that community to do a direct head-to-head comparison of community-based and residual specimens for measles serology in this community. And then as we speak, we're nesting a measles serosurvey within a nationally representative demographic and health survey that's being conducted now in Zambia. So these kind of nationally representative HIV surveys or demographic and health surveys provide a really nice platform to leverage a representative sample for other pathogens, to conduct serosurveys for other pathogens. So just to give you I'm not going to spend a lot of time talking about data, but this is comparing the residual specimens from the community, from a household-based measles serosurvey, with the facility samples in 2 districts in Zambia. On the y-axis is measles seroprevalence. You can see 2 age groups there. And in general, I think it's obvious that our point estimate of measles seropositivity was lower in the facility residual specimens than in the community specimens. And as Tim alluded to, and I'm sure that there'll be more discussion here, it sounds like, there are ways to try to adjust these results, trying to get better age matching, for example, or if with your residual specimen you have some information on location. We usually don't kind of get an address in Zambia, but maybe a village name, or you can do some matching or exclude children who came from outside the community. So there are ways to adjust these types of estimates. We interestingly saw a closer match between the community-based serosurveys and specimens that were really collected as part of a measles fever rash surveillance system, which was kind of interesting because we thought these might be even more biased because these are children potentially presenting, although you can exclude obviously the IgM positives here. But we did get a much closer match between what may be the gold standard, the community-based serosurvey, compared with the residual specimens that were collected for another purpose, for IgM testing. So that's just a little bit on the feasibility, and all of you are very, experts in kind of the feasibility of these, of serosurveys and thinking about the most efficient and effective and representative ways of collecting samples. I'm just going to highlight some of the utility of it, and we're going to talk more about this, I'm sure, throughout this conference. But one thing is obviously estimating disease burden, and one of my favorite use cases for this is for surveillance for congenital rubella syndrome, which in a country like Zambia and many countries throughout the African region and Asian region is very poor. And so one can take age-specific rubella seroprevalence curves and model out the burden of congenital rubella syndrome, and that's really how we get our estimates of congenital rubella syndrome. And so this was work done by our colleague Amy Winter, who's now at the University of Georgia, who's an expert in rubella modeling. But across the provinces in Zambia, this shows the risk of congenital rubella syndrome in women of childbearing age based on the age-specific fertility rates. So I think this is a good example of really getting at an estimate of a disease burden that's really otherwise invisible to the surveillance systems that can be done through serology. Obviously, certainly in the world of vaccine-preventable diseases, identifying immunity gaps is a real critical contribution of serosurveillance. And particularly for diseases where you've got endemic virus transmission as well as vaccination. And Tim showed the data for SARS-CoV-2, where there's a nice way to separate exposure to vaccine and exposure to wild-type virus by looking at N and the spike protein antibodies there. It's not so simple for diseases like measles. One of the holy grails still is to have a serological assay where you can distinguish wild-type from vaccine measles virus exposure, but we don't have that yet. So we look at immunity. So it's very difficult actually to create age-specific immunity profiles by triangulating other data, case-based data, vaccine coverage data. And so serological data really provides you with that really direct measure of immunity profiles. And so you can look at immunity profiles by age on the far left, which is the curve that we saw in Zambia. Interestingly, we saw an immunity gap in young adults in measles in Zambia. You can look across certain subpopulations of interest. One of the values of us nesting a serosurvey within an HIV biorepository is that we had access to then HIV infection status. And we saw this very striking difference in measles seropositivity in people below the age of 25 or so, between people living with HIV and those without HIV. So there is actually in Zambia a huge measles immunity gap among people living with HIV. And then obviously, so you've got age, subpopulations, and then obviously across space. And using a nationally representative sample gives you the power to look at immunity gaps across space. That study was powered at the provincial level, but again, through modeling work and small area estimation, you can bring those estimates down to the district level, obviously with certain with uncertainty bounds there, but get this kind of picture that you see on the right of Zambia with measles seroprevalence at the district level. And that can be very valuable in terms of targeting immunization activities, and I'll come back to that. One can also evaluate program impact. So what we did in India was did measles and rubella serosurveys in 4 districts across 4 states before and after they did a measles and rubella mass vaccination campaign. It was actually the first introduction of rubella vaccine into the country. And so the blue lines here are the modeled estimates prior to the mass vaccination campaign. The red lines, the seroprevalence estimates after the mass vaccination campaigns. You can see in most states across most ages, those immunity gaps were filled by the campaign, but in some districts and states, like in Uttar Pradesh in northern India, there remained immunity gaps even after the mass vaccination campaign. So using serosurveillance for program impact. And then lastly, a lot needs, in these settings, a lot more work needs to be done to fully realize the value of serosurveillance. And where Andrea and I are working on, there's a lot of interest by Gavi and the World Health Organization in having some countries move away from these mass vaccination campaigns to more tailored and targeted strategies. And we think serosurveillance could play a key role in guiding, where the resources need to go and evaluating how those countries do. And I'm just going to show one more slide that may be a little difficult to see, but this is the work that Andrea led using multi-pathogen serosurveillance. This was work in Mozambique, where we collaborated with the CDC and the London School of Hygiene and Tropical Medicine and used this multiplex bead array to measure IgG antibodies to dozens of pathogens. And I think, as Tim alluded to, I think this is really the future, where you can really leverage enormous value. And so what we're showing here, you can see the antigens, perhaps you can see the antigens or pathogens listed on the left there, and this is just showing age-specific seroprevalence estimates in 3 age groups. But this is enormously rich data. It has its own kind of analytical challenges, but I think this is what we're going to see more and more of as countries move forward. Thank you, and I'm going to turn it over to my colleague, Andrea Carcelin.
Thanks, Bill. As has been mentioned, I'm just going to talk briefly about some of the findings from the Serosurveillance Summit, which was conducted in March of last year. And we brought together people who had experience in using multiplex bead assays, because as Bill noted, this is kind of what we see as the future for serosurveillance. And as others have mentioned, the value for money, right, I think is maybe a stronger case once you look at a variety of different pathogens. And so the objectives of that meeting were really to share experiences among people who have done this in a number of low and middle income settings. We wanted to talk about, what are the challenges in kind of setting up this serosurveillance system, what are some of the opportunities going forward, and really get people together in the same room, I think much like this, to talk, because everybody's maybe doing their projects kind of individually or talking to 1 or 2 other collaborators. And so this was really the opportunity to bring everyone together and establish that community of practice. So here you see just a photo that we took at the school, and we had 87 participants. It was hybrid, though most people were in person. And it included representation from research institutions, from CDC, from the London School, Institut Pasteur, and a number of different academic universities. We also had representation from WHO and PAHO and CDC Afro. We did include funders. This was put on by the funding from Bill and Melinda Gates Foundation. And we also had Global Fund representation as they are starting to move into the serosurveillance space as well. And because we focused on multiplex bead assays, we did have some private industry representatives there for a number of challenges that have come up for our countries in terms of procurement and instrument maintenance. And then you can see the country partners here. There were a number of countries represented who have done or are in the process of establishing serosurveillance. But there are certainly others that were not able to come as well. And this meeting was also building off of a previous meeting that had been held on serosurveillance and kind of multiplex as the future of serosurveillance in Annecy, France. But this one really focused a lot more, I think, on low and middle income countries who might see some of the most benefit from multi-pathogen serosurveillance. And so everyone was divided up into these 6 working groups. And we had the session split so that people participated in 2 working groups. So there was a lot of kind of cross-pollination of ideas. The working groups included use case scenarios, which is kind of what we think about in terms of how can serology inform programmatic decision-making. Seroepidemiology really focused on the study design questions, sampling strategies, how you handle different target populations for different pathogens of interest and kind of come to a consensus, and then ways to address biases given study design. The data analytics group focused a lot on the analysis and the modeling and how to triangulate seroepi data with other sources of surveillance. And then the supply chain, I think as inherent in the name, focused on the assay availability, reagent manufacturing, equipment, and technology transfer. And finally, sustainable implementation really thought about how the program could continue to fund this in low and middle income country settings and get political buy-in. So I'll just go through a few of the findings here. So the first is in use case scenarios, which I think Bill and others have alluded to already, the burden and distribution of infections in terms of complementing our existing surveillance systems. It's particularly useful when you have infections that are mild or there's poor access to care or there might not be accurate diagnostics. So through serosurveillance may be the best picture to kind of get that true burden and distribution of infections. So for each of these, we just have one example. So this one on the right-hand side is just a nationally representative sample of dengue seroprevalence in Bangladesh with the reference to the publication for those. The second use case was with one that's probably very applicable to this group, but the identification of emerging and re-emerging infections. So tracking things like SARS-CoV-2. And the example here on the right is a study from Mexico looking at SARS-CoV-2 seroprevalence and how that expanded through the country. But it can help to track other outbreaks of kind of re-emerging pathogens, Zika, chikungunya, Ebola, Lassa fever, and I think Mpox has also been mentioned here. But the idea being, right, things that are new or coming back up in countries. The third use case, which I think Bill presented already previously, was really evaluating the vaccination programs, whether that's identifying immunity gaps where vaccination needs to be targeted, or actually evaluating a vaccination campaign. And that really is focused on pathogens that have vaccines available to them. And so this is just the reference to the same slide that Bill had shown in India about closing population immunity gaps following a campaign. The fourth use case is similar to the previous one, but it is really looking at the effectiveness of interventions that are not vaccines. So whether that's behavioral interventions, environmental or pharmaceutical interventions like bed net usage, water, sanitation, and hygiene interventions. The example that you see here is on bed net distribution and the effect on malaria seroprevalence in Mozambique, with blue being before and red being afterwards. But there was an acknowledgement here that for some of these interventions, IgG serology may not be the best way to measure that effectiveness, for example, on antibiotic usage. So there was a little bit more work that the group wanted to do kind of on fleshing out this use case specifically. And then the fifth use case was on monitoring peri and post-elimination surveillance settings. So this comes out of a lot of the work that's been done on neglected tropical diseases, and where they've been using serosurveys for a number of decades, and using that both to verify elimination of transmission and then monitor for any gaps. And so it can be used for a number of different pathogens, including onchocerciasis, guinea worm, trachoma, and polio. And so the example here on the right is onchocerciasis elimination in Uganda. Ooh, thank you. Yes, didn't click, sorry. So this example is onchocerciasis elimination in Uganda. So this is 4 pathogens that have an elimination of transmission target. And so those are the use cases that the group kind of came up with. And there's more detail certainly in the report that Tim mentioned. And we also have a manuscript that will be coming out that's a little bit more succinct than the 80-page report. So I'll transition now to just a few of the kind of conversation pieces from the other working groups. In terms of the SeroEpi group, they talked about a number of study design questions. So when would repeated cross-sectional surveys be better versus longitudinal cohorts? What's the different types of information that you could get? One question that's a big interest to the funders is how frequently do you need to sample a population in order to kind of see a change and a meaningful change? What are some less resource-intensive ways to do representative sampling? So I think Bill talked a lot about that and how we combine different sources. Then kind of sample size and sampling approaches get really complicated when you're looking at multiple different pathogens and having enough power to see, answer the research question in your particular group of interest. And then, of course, data. What are those core data elements that you need for each of those pathogens to be able to collect? And then pairing, the pathogens or the antigens of interest with your clear scientific policy questions. So then on the supply chain group, they talked a lot about purchasing and maintaining of instruments in the low and middle income countries and the challenges with that. The process of coupling beads is technically challenging, and there are a few labs that can currently produce those coupled beads, but there's a great demand from countries who want to implement serosurveillance. So thinking about how do we make that more accessible? So there was some discussion about creating a commercialized kit and what would be needed in order to do that. But there were maybe different camps in this group because creating a commercialized kit would make it more available to more people, but there would still need to be a lot of support on the data analytics and interpretation side. And it would also take away potentially the country's ability to personalize their assay and may require them to test for things that they're not interested in or wouldn't act on. So that one, I'll say, caused a good bit of debate. And then there are a number of cold chain challenges, particularly in low and middle income countries. And then some country-specific limitations around the ability to procure, the ability to get things through customs, getting ministries to kind of approve different aspects of serosurveillance. And then, as has been noted, I think by Tim, the human and technological capacity challenges kind of across all of these. So then on the lab side, I will say that there's a good bit of overlap kind of between these groups, partly because it's the same people participating in the groups, but partly because a lot of these issues are inherently overlapping. So here we had a lot of leadership from the groups who've been doing serosurveillance, like CDC and the London School, RAVM out of Holland, Hopkins and Colorado University, that talked about what are their approaches to technology transfer and could tools be developed or trainings be developed to help support this to more countries. There was a lot of discussion about sharing kind of best practices and protocols and on some form of platform. There's a good bit of discussion around standardization in terms of assay development, antigen discovery, appropriate controls for different panels, particularly when you're looking at so many different pathogens. And then quality control metrics that were needed in order to assure kind of that everyone is looking at things the same way. So then on the data analytics side, they divided up their kind of issues into these 3 buckets about standardizing and cleaning data that had a lot of overlap with the lab group, translating cleaned data to be able to make epidemiological inferences, and then developing these user-friendly analytic and visualization pipelines, so ensuring that the data actually is able to be used by program and policymakers. And so I won't go through all of these, but a number of them had to do with kind of having appropriate controls and standards across all of the different pathogens, and establishing kind of those cut points for seropositivity, and making sure that one cut point used in one place was comparable to another. Because for some pathogens, there are international standards that exist, like in the vaccine preventable disease world, but for many of these pathogens, there are not. And then on the sustainability side, I will say this was led in great part by the Pan American Health Organization, who has developed a toolkit for integrated communicable disease surveillance. So if you haven't seen that, it is a nice reference guide. It's not guidelines from the WHO, but it's really intended for ministries in the Americas region who are interested in doing serosurveillance to go through and see, what are possible antigens that can be put on a panel, what would that tell you, what are the age groups that would target, and just kind of walks you through serosurveillance. But so they presented a number of their experiences in terms of how to demonstrate that added value of serosurveillance, particularly in settings where there are lots of competing interests and wanting to set up genomic surveillance and wastewater surveillance and also maintaining traditional surveillance systems. Why invest in serosurveillance also, particularly when you're having to kind of set it up from scratch. Getting buy-in across the health system, so because you are including so many different pathogens, right, you have to have the NTD group on board and the malaria group on board and the expanded program on immunization group on board. And so getting kind of everyone into that room and in agreement on serosurveillance is a challenge. The third is, as has been mentioned, lab capacity, supply chain, procurement, funding, kind of all of those pieces that need to be there for operationalizing. And then the fourth one is the use of the data, making sure that it's done kind of in a timely manner for programmatic action and really in a digestible format for programs. So I think you've probably heard me say a number of things that are cross-cutting, and so we developed this sort of cross-cutting solutions list that all of the groups really advocated for some type of digital platform to share information across experts who have been doing serosurveillance, so whether that's a GitHub to share code for data analytics, a Slack or website to share things like lists of supplies that are needed, existing protocols, antigens that people have tested that have worked or those that haven't worked, so that you're not kind of recreating the wheel when you're looking at assay development, quality control procedures, and then things like our Shiny apps to help with the analysis side. In terms of building local capacity and training, many of the working groups suggested building in-country capacity for a number of different topics, including supply chain logistics and equipment maintenance, sampling and how to approach different sampling structures, actually running the assay, and then data analysis. There was also a suggestion for creating a network of laboratories and how this could potentially be modeled off of SeroNet in the US or other global lab networks, such as for polio or for measles and rubella, where you might have regional hubs in different continents or even maybe at the subcontinent level, and those labs might actually focus on different aspects of serosurveillance, like one may focus on coupling beads and providing that for the neighboring countries. One might focus on, controls and standards. And so that, I think, is continuing to be discussed amongst a number of different groups. And then the last one is really generating political buy-in and having, whether that's briefs or PowerPoints or some sort of explanation that's simplistic to really demonstrate the value add of multiplex serosurveillance, and getting that buy-in from the governments, from funders, and from the implementers. So that includes the use case examples that we've talked about, but then also generating interest amongst that kind of value add aspect in economics. So just to close out kind of the next steps, I've just included a link here to the report. We're trying to maintain this community of practice with continuous meetings, and then trying to address some of the short-term solutions that were identified through the meeting, with an eye towards some of the more longer-term solutions. And the Bill and Melinda Gates Foundation has, I'll say, expressed interest in planning a follow-up meeting in late 2024, likely in one of the countries that they are funding for serosurveillance in Africa. So more to come. Thank you.
Thank you, Bill and Andrea. I know we have 15 minutes, so for those of you online and those of you in person, if you have any questions, please make your way to the microphone. And I see Agatha is there. Agatha, over to you.
Can you hear me? Yes, okay. Thank you for that excellent presentation. I want to come back to something that I think, Bill, I heard you say sort of at the start of your presentation, was that the use of residual samples and the sort of secondary testing, especially on samples submitted for diagnostic testing, maybe get some negative feedback. And, public health isn't always the favorite of some folks anyways. But it's not really a conversation that we're necessarily having in these meetings. And maybe some of us are avoiding it. But when we do these surveys and disseminate the results and they affect policy, can you share your thoughts on, how can we sort of get around maybe the negative views around the secondary use of samples, and what sort of conversations you're having in your networks?
Yes, thank you. It is a really important question. And a lot of people in the room know a lot about the use of residual specimens. And so I can speak kind of from, my experience in Zambia, which is different. But I think, one whole issue, and I know we're going to discuss it more here, is just the ethical issues and consent issues around using residual specimens. We have not, we've been able, both in India and in Zambia, to successfully access and test residual specimens from healthcare facilities and from laboratories. So that certainly hasn't been an insurmountable problem in those settings. A second challenge, again, well recognized here, and Tim alluded to this, is that the availability of metadata, and that's actually also linked to the consent issues, and so, obviously there's kind of a minimal set of data that's required to interpret, particularly the age or some age category. It's nice if you can have some spatial data. And then, I think the big question that we've encountered, and I'll say it's largely been in discussions with the Bill and Melinda Gates Foundation and their surveillance team, is the representativeness of the data. And are the seroprevalence estimates that you're getting from the use of residual specimens, really accurately represent the underlying population seroprevalence, which is it's a reasonable question. I think it's it's also a complex question because I think it's going to be very context specific. It's going to depend upon the pathogen. And I think for SARS-CoV-2, as you've seen in HEMANET, it wasn't an issue. You know, that was a new pathogen into a completely susceptible population, probably less biases. But for like a vaccine preventable disease, which requires a child to be, you know, access healthcare services, then there may be more biases there. It's also going, yeah, so I think that's an issue that's just very context specific, and it's a tough one because I don't think we want to land in a place where every time you use residual specimens, you have to do some head-to-head comparison with community-based specimens. And as we know, even you know, household community-based specimens, the gold standard with great study design, those aren't completely representative as well. You're missing populations. And we actually in Zambia did what we call our missed population study, where we went back to households that refused participation or where there was no one. For vaccine preventable disease like measles, this is really important, particularly if you're missing, you know, because if there are communities that just aren't part of your sampling frame or populations that aren't part of your sampling frame, those too could be the communities where the children are unvaccinated. So that is a challenge, and there's no simple answer there. But what I hope, to kind of get to your question, is that collectively we can make a case that there is, in certain contexts and certain pathogens, there is a real role for this. And my kind of one vision here for Zambia is that you do these nationally representative household-based surveys, you know, leveraging existing ones like a DHS survey or other surveys to kind of really anchor your prevalence estimates. And then you could use residual specimens to monitor trends over time. Maybe it's not giving you the actual point prevalence that, you know, but it's going to be a helpful marker for trends over time. So that's one really powerful use case, I think. The other is that for some decision making, you don't need a point estimate. You just want to know whether you're above or below a certain threshold for decision making, like should I do a mass vaccination campaign in this district or not? And there too, residual specimens, you know, may be valuable enough for that decision making. You know, to tell you whether you're above or below a certain range or threshold for decision making. So I think there still is, in some communities, I think there's an opportunity to make a use case of the value of residual specimens. That's a long answer to your question.
So as you mentioned, the three main pillars of a strong Sero survey is, of course, high quality of the sample, the technology, data, harmonization, standardization. So I think it's important to think about what residual samples can measure and what they will not be able to measure, as well as the assays, you know, so fit for purpose analysis. So, you know, my questions are around how do we control for heterogeneity across residual specimens? In some cases, you may want just a positive, negative, but if you want to fully leverage data for other types of decision-making, the quality of the sample is going to be very important, as well as how you process that sample. Yeah. And if you are going to biobank, do you have limits? Do you say, okay, I'm going to only use, you know, these samples that were collected within 24 hours of processing or testing? So I would like some reflection, to see some reflections across that, the control for heterogeneity. Then we did a lot of assay comparison studies. So we have been leading an HPV serology standardization initiative funded by the Gates Foundation and National Cancer Institute on HPV since 2016. And we have done a lot of assay comparisons. What are the best assays for certain purposes? And if we cannot have everybody using the same assay, how do we standardize? So also, building those standards is going to be very important, because when you want to pull data even from different testing sites, you want to make sure that the data and the assays are all standardized, are speaking the same language, utilizing the international standards. We have been working very closely with NIPSC and WHO to build those standards that we are making available to the community. And we are actually which is very interesting because that's why I think there is a lot of silos sometimes. So these meetings are, thank you so much, are really good for knowing what you are doing, because we are actually expanding capability of testing for serology in different countries around the HPV specifically. So this is, just some reflections about these aspects. Thank you.
Do you want to start or want me to start?
I can start. Maybe it builds a little bit on the last question and on this question. A lot of the work we did was around measles and rubella, and I think as we've expanded into the multi-pathogen space, some of these questions get trickier because there are international standards, right, for measles and rubella, and there are not for a number of pathogens. There's also the ethics question came to mind, and particularly with HPV, right? If you're using residual specimens, often you can't report back to the participant, right, if whatever your findings are. So this has come up a lot on the multiplex panel, and if you're testing for HIV, right, that responsibility to feed that information back to the participant, it's a challenge if you're using residual specimens because they're de-identified. And so what's the ethical responsibility there? And yeah, in terms of controlling for heterogeneity, I think that's I don't know that we have answers necessarily. We have, in our head-to-head comparison, tried to do some comparisons of what are the biases and what are some potential ways to control for that. What if you didn't have this information? Would your kind of response be the same? And kind of looking at it from that aspect, but.
Yeah, I'll just add to Andrea. First on the quality of specimen, obviously critical. We worked in health centers and hospitals in kind of rural Zambia, and definitely faced challenges with specimen quality. But we're able to do it, and even in those labs. I think a really challenging question that we've faced, and you alluded to, is the assay performance characteristics, and we've seen this kind of in two areas. One is we have used commercial measles and rubella IgG kits, which are not designed for population serosurveys. And particularly the sensitivity at the lower limits of detection, where you do not, to say it simply, you do not get very nice bimodal curves with your OD values. The only place we see that is prior to rubella vaccine introduction. Wild type rubella will give a nice bimodal curve, but the measles, no. So your seroprevalence estimates are very sensitive to where you set that threshold. And so we have done head-to-head comparisons with enzyme immunoassays and plaque reduction neutralization tests, and with the CDC multiplex bead assay, where they have done head-to-head with PRNTs and saw good correlation. So that has allowed us to do we approach this in two ways: linear adjustments, particularly when we want to use the quantitative values, and adjusting the threshold of calling seropositivity. But that is a huge challenge in this field. And when we turn to the multi-pathogen serosurveillance, it's even more complex, I think, because there aren't gold standard assays often to compare to. And so our team has done a lot of work on trying to think through how do you actually set those seroprevalence thresholds or seropositivity thresholds where you've got unimodal distributions, and using mixture models do not always work. So I think there's a lot of work to be done, and particularly as we move to more the bead-based assays, multi-pathogen, multiplex assays, in figuring out on the analytic side how we set those thresholds. But a big challenge ahead, yeah. And maybe I'll just say, I know there are two more questions. Thomas has a question, but I think one of the biggest threats to this field particularly if there's not here in Hemanette in Canada, but as we try to move this out into low and middle income countries, is that we get a lot of poor data coming off the pipeline fast, because I think it's just gonna, people will lose confidence and trust in the assays, and then we'll lose our momentum. So I think we need to be particularly careful as we're trying, just at the start of this initiative, to really move this out, to have high quality data come out, because otherwise we'll shoot ourselves in the foot, and people will not trust the data.
I also comment on the last question of the heterogeneity or comparability of assays. So we were shocked at some point in 2021 when we looked at the FIND website, and there was, I think, 250 different serological assays, most of them not validated, for SARS-CoV-2. So how do you navigate that landscape of so many tests? Luckily, with many other emerging infections, there's much less tests. For Zika, it was 4, I think. So, but we have the comparability issue. We embarked, and I would love to talk about that more, on a project bridging studies where we downloaded all the published literature that had more than 2 tests applied to the same sample and tried to come up with a network analysis comparison, but more on that later. The other point I wanted to make is, can we come up with an agreed language for broad informed consent? So we stumbled on that point again and again. So in the Zika cohort studies I coordinated in Latin America, we had a broad informed consent included for sample sharing, and for some reason we didn't include it for data sharing, maybe because we thought, okay, if you share samples, data is easy. But now the lawyers have us come back and get waivers of consent for data sharing, and as you said, or Tim said, there's at least a core metadata set needed. Only samples without any data is not worth a lot. So, and the funding agencies, really, they have the power to say, okay, if you get money, please include this broad informed consent statements in your ICFs. And I would really pledge for that. That would help a lot for us.
Just one last question. We're running out of time, so a short one, please.
Hopefully it's not too long, and also happy to discuss it afterwards if there isn't time. But you mentioned the difficulties of advocating for serosurveillance in the setting where there is competing interests from wastewater surveillance, genomic surveillance, etc. So do you have any strategies to share, or any arguments, wonderful arguments to make to policymakers, funders, etc., to actually highlight the value add of serology versus the other approaches?
You want to take that one? I think we've tried to present our work to the Gates Foundation, CDC, WHO, on the value of serosurveillance. And I think obviously each of the different types of surveillance system provide, they provide different information. And there is this higher level kind of global effort to try to really develop integrated, or what are called collaborative, one new phrase is kind of collaborative surveillance systems. And I think there's still a lot of work to be done to show how these different data streams can really be triangulated, and how they complement one another. So for example, I don't have a lot of experience with wastewater surveillance, but I see that as kind of a signal detection system. So you can detect a system early, but it's not going to tell you anything about risk factors, age distribution of infection. That's where serology can come in. So I could, just in very naive, crude answer, I could see wastewater, surveillance being kind of your signal detection. You get a signal, and then you do a serosurvey, and you can identify, risk factors for infection, something like that. So I think we need to, a lot of these things are kind of done in silo, but I think a lot more work can be done to figure out how to triangulate these different sources. And then our colleagues who do modeling can, perhaps do their magic and bring some of these data streams together as well.
All right. Thank you so much, Bill and Andrea. If you have any other additional questions, those online and in person, please email me, and we'll compile a list and circulate the answers at the end of the event. Just wanted to thank Bill and
Thank you.
Andrea again for your time. And we look forward to aligning our efforts moving forward.